Yes, we are live on the YouTube. We'll start in a while. Okay, good morning, friends. Welcome back to Saturday Club morning meeting. And today again we have Dr. Jaimin for talking to about shoulder pathology, recent advances in the management. Dr. Jaimin Jasalpura had already given the part 1 talk in the last month. So we all know him, but to briefly introduce him, he's a consultant orthopedic surgeon in Vadodara. His special areas of interest are arthroscopy, sports injury, and joint replacement. He was past associate professor at SSG Hospital, Vadodara, and he got trained with fellowships in South Korea, UK, and India, and currently director of the Vaishwi Hospital. So with this brief introduction, welcome back, Dr. Jaimin Bhai. Over to you for your talk for about 40-45 minutes. And again, we'll have discussion for 10 to 15 minutes. Over to you, Dr. Jaimin.
Thank you, Satish Bhai, for your kind words again and introduction. Good morning all to all senior doctors, consultants of Baroda, and good evening to Dr. Satish Bhai over there. So I will be sharing my screen.
Yes, please.
Yeah. Okay, I think you got it. So
yes.
So we were discussing last time regarding shoulder different pathologies, and we had discussed a part of it regarding rotator cuff pathology in last meeting. So I will just go through briefly about different pathologies, and then again we'll go on the instability part in this. So what we have discussed last meeting was that we have got two kinds of patient who approaches us in our OPDs. One is elderly patient who are beyond 50-55 years of age, and one is the younger patients. So the pathology is different in both age groups. That is what we commonly find. So your shoulder is having very fine balance. Your shoulder gives you almost 360-degree range of motion. So it is a bit highly unstable joint in your body, but at the same time, it gives you a very good mobility. So this mobility comes at the cost of stability. And there is a fine balance between your rotator cuff muscles. As we saw last time, you have got 4 rotator cuff muscles in the shoulder. You have got a subscapularis in the anteriorly. You have got infraspinatus and teres minor posteriorly. And you have got supraspinatus here superiorly. So there is a fine tuning between your supraspinatus and deltoid, which keeps your joint reaction force towards the center of the joint, and it helps you to give pain-free range of motion in your shoulder. So this is one of the most important thing to have healthy shoulder and pain-free range of motion. So in the last meeting, what we saw was the importance of your scapular stabilization and how your scapula and your shoulder functions together to give you overhead abduction. What were the different pathologies, particularly what we see in our OPD practice is more of, frozen shoulders. This is the only terminology which even we knew when we were studying, but it's just a tip of an iceberg, and you have got many different pathologies which is lying below that. So we'll also that these are the routine x-rays what we take in our OPD, or we can ask the radiologist to get it done for us. And what we see many times is the fractures, dislocations, arthritis, calcifications. So these are all different pathologies what we can find on routine X-ray. However, one of the very important investigation here to diagnose the shoulder pathologies is sonography, ultrasound. So it gives you very good idea regarding your bursitis, partial cuff tear, health of rotator cuff, many inflammatory arthropathies, which can be diagnosed with the arthroscopy. So is the last time what we went through regarding the frozen shoulder, and there are different modalities. I'm just revising a bit, few slides, so we can get into the overall picture of the shoulder pathologies. So for the frozen shoulder, the routine, the line of management is to make the patient pain-free. We give them ice pack, physiotherapy, and NSAID to get them relief. But many of time what we have seen that it takes long time and it's very painful condition. So we do advise them sometimes in non-diabetic patient, intra-articular steroid. Few of the cases, if the physiotherapy is not, patient is not able to comply with the physiotherapy or the patient is not improving with that, we can go with the hydrodilatation. What I mean by hydrodilatation, we all know your joint has got a space and you inject almost 60 to 100 ml of distilled water along with the steroid and anesthetic agent inside the joint, and you balloon it out. So when you balloon it out, your capsule gets stretched, few of the adhesions get torn off, and that's how the patient gets good movement. So this is a controlled procedure rather than mobilization under anesthesia. What we used to do in the past, that you give a short general anesthesia and you mobilize your shoulder joint and it gets free from all the adhesions. But nowadays we usually avoid that procedure. It is not a controlled procedure, and you don't know. Sometimes in osteoporotic bones, partial cuff tears, you might go ahead and rather damage your shoulder more than rather than giving a good treatment. So one is the physiotherapy, second is hydrodilatation, and the last part comes the arthroscopic release, where we put a scope inside the shoulder joint, and as per the MRI, the commonest ligament which is contracted is your IGHN. There is an inferior glenohumeral ligament and the rotator interval. That is where the pathology lies. And we go ahead with the scope inside. We put a portal, and if you see here, this is a radio frequency probe. And with the help of that probe, you start cutting your capsule. And then with the help of different instruments, you go and cut your capsule. So if you see, this is your humeral head and your glenoid is below, and gradually you are increasing the space of the shoulder joint. So this is the long head of the biceps, and many of the times we do tenotomy of long head of the biceps. This is a rotator interval which lies just above the subscapularis tendon. So we release it. So this is your glenoid. Now it's a bird's eye view. We are looking from the top here. And if you see my instrument here, it is exactly at the 6 o'clock position in the inferior portion. And you do a good capsular release 360 degree, and you can have a good space after that within your shoulder joint. And this patient does well post-operatively, again with good rehab and analgesics. So we do shoulder arthroscopy in frozen shoulder, but in very, I would say maybe 6 to 8 patients a year, not more than that. So majority of the patient we try to manage with the physiotherapy and hydrodilatation procedure. Few of the other cases, excuse me. So this is a subacromial decompression. What I mean by that, we are just below the acromion process and above your rotator cuff muscles. So many of the times you have got calcification, bony spurs here. If you can see here, your rotator cuff tendon is torn. So we do a good arthroscopic subacromial decompression to get that space back. If there are bony spurs, with the help of burr, you can remove that part of the bone as well. So these are all soft tissue procedures, very fine tuning you need here. And you can visualize your pathology and correlate with your pre-operative MRI findings as well here and do the good job for your patients. So as we discussed last time, the commonest pathology, what we found beyond the age of 55-60, post-traumatic, is rotator cuff tear. So what happens once, if it is a post-traumatic, within 2-3 weeks, if we don't check these patients for the power, particularly, if you don't examine them properly, then definitely the X-rays are going to be normal. So this patient gets pain-free by 2 to 3 weeks. And once they are pain-free, they resume their routine work and it gets neglected many a time. So when the patient comes to us after 6 months down the line, then they say that we have got night pain, which is very common, weakness of shoulder, and they will have a continuous arm pain on the side of the arm, which is not going away. So that's how you examine, very old slide, 10, 15 years back. So that's how you examine for this patient for the power. MRI is the diagnostic of choice. Yes, I told you, USG is a very good screening and diagnostic test for all shoulder pathologies. That's how we repair it. We repair this tendon, put this anchor in, and there are threads with this anchor, and we bring this cuff back onto the bone. And that's how the bony healing starts from 6 to 8 weeks. This heals with your native bone. And that's how the post-op X-rays look. As you do arthroscopically. So these are the few pics. If you see, is your humeral head. That is your tendon. We put an anchor which are already preloaded with the threads. We pass these threads through these rotator cuff muscles, tendon, and then you tie the knots. So the ideology is to bring back this tendon in contact with the bone, and so as the natural healing will start. So that's a brief, very brief video regarding same. So we are working just below your acromion process here. And that's the anchor which is going inside the bone. And that's this, if you can see, we pass these threads through the tendon. So different instruments are available for this. And the advantage of arthroscopy is that you can find out many hidden lesions in the shoulder joint. At the same time, many times, few of the things you miss in MRI as well. And we see a lot of subscapularis tear, which was not mentioned in the MRI many of the times. So if you see here, this is your rotator cuff is back on the shoulder. And this is what I am doing, double row repair. So I'm putting one more anchor here along with these threads. So this will pull my rotator cuff tendon. Okay, so if you can see, it's like a parachute. So like in parachute, you tie your rotator cuff with the humeral head, and that's what is known as a double row repair. So once again, you go inside the joint, and you can see this is your subscapularis, this is your humeral head on the right side, and your cuff is well in place. Many a times we do operate patients of rotator cuff tear beyond the age of 70, 75, I would say close to 80 as well. For a long period of time, I've shifted from many times you have to do reverse shoulder replacement in this kind of cases. But there are different modalities with which you can still preserve your joint. You can reroute your long head of biceps. You can remove it from the bicipital groove. You can change the course of the long head of biceps, fix it so as it will avoid proximal migration of the humeral head, and then you can repair or partially repair this cuff. So these are different modalities with which you can preserve your shoulder joint and you can prevent the arthritis. So that's how it looks. There are a few patients, young patients, when they come very late to us, and this is a 55 years young lady, and she presented to us after 1.5 to 2 years of rotator cuff tear, and that was the case when we had to do a biceps rebooting as what was showed previously. So you can't do reverse shoulder in so young patients. You need to preserve their shoulder joint, make them pain-free, and let them do their all routine activities. It's a very good procedure which can save your shoulder joint. So there was a few slides regarding my first talk, which I want to revise it, particularly for the frozen shoulder, diabetic frozen shoulder, rotator cuff tear, how it can be managed to preserve your joint rather than getting into the joint replacement. So another part of your shoulder joint, as we have seen, it's a highly unstable joint. It's a big ball on the very small socket. It's not like an joint like knee joint or hip joint, which are inherently very stable joint. So recurrent shoulder dislocation, which is very commonly we see in a sportsman or younger age group. But majority of time in our scenario, we see these patients post-epileptic as well. Particularly the epilepsy, which is not well managed, patients are defaulters, they are not taking their medications regularly. So epileptic patients, post-traumatic again, pulled elbows, pulled shoulder, like, so those are the patients what we see a recurrent shoulder dislocation. Why we have used the word recurrent? Because once the patient gets his shoulder relocated, usually it's the upper limb. So it doesn't, 3 to 6 weeks down the line, they do well. And many of the times they don't do good rehab. And then it goes for a recurrent dislocation. So when the patient reaches to us conceptually for the surgery, they have got dislocation not less than 8 to 10 times. And many times this patient reaches us 4 or 5 years after. So we need to evaluate these patients in form of not only MRI, but now we get them their CT scans very regularly. Why? We'll see in next few slides. So what happens in dislocation of shoulder is this labrum, which gives you a stability to your joint, gets torn off. And when you put scope inside, that's how it looks. And what we do, we put an anchor, we bring this labrum back into its normal position and suture it back. So your glenoid is inverted pear shape. So it is bigger inferiorly and smaller superiorly. So now we're going in detail, but as I told you, we need to get the CT scan to see the width of the glenoid. Because when this patient reaches to us, they've lost a lot of bone. So now, in almost all our patients, we get the CT scan, we compare it with the normal shoulder, and we always see how much bone loss has happened inside. We just don't go by just MRI and go ahead with the surgical management. So these are few of, I'm not going in detail, but that's how we do it. Previously, we used to do this surgery by open means, but here you need to cut subscapularis muscle anteriorly, subscapularis tendon. So it does affect your final range of movement. So there are few cases where patient will get restricted range of motion with open surgeries, and with arthroscopic surgeries, you can do this only with 3 holes, not more than that. And you can put your anchor in and put this labrum back on this glenoid again, and you can repair it with arthroscopically. So that's how we do it. Again, there are a few videos. So this is your glenoid inferiorly. This is your humeral head superiorly. This is your long head of the bicep on the left side. This is your rotator cuff muscle. So this is your diagnostic arthroscopy. And so you can very well see your humeral head lying inferiorly here. So that's where your labral lesion is there. And we want to put this back on the glenoid here. So now we are visualizing again superiorly from here. So this is your glenoid, and that is superiorly is your humeral head. So I want to put this anterior end of bend of IGHL back to its normal place. So that's how we release our capsulolabral structure. This is the anchor, what we are putting in. You can see it is all suture anchor. You won't be able to find these anchors in post-op X-rays. And with these threads, we tie this labroligamentous complex back on the glenoid. That's how we do it. So that's your final picture. So you put this labroligamentous structure back to the glenoid, and it heals well within 6 weeks, and then gradually you can mobilize these patients. So many different things. That's how it looks if you use your titanium anchor. This is how it will look in the post-operative X-rays. As I discussed with you, if there is a bone loss, we need to pick it up in the CT scan, and then we use this coracoid process to fix it. Because now arthroscopy is not going to work in this patient. So we need to put this coracoid, which is known as a Latarjet procedure, and we fix it over here. This is a patient with a cyst. If you can see in the MRI, this young patient, young chap was having weakness in the shoulder. He got to the neurosurgeon, neurophysician, and when we see the shoulder MRI, it was the cyst which was compressing at the spinoglenoid notch on your neurovascular structure. So you can very well go in arthroscopically and you can release it. So arthroscopically you can reach there. It has got advantage of less blood loss, technically very precise procedure, faster recovery. We keep this patient just 1 or 2 nights at our hospital. They get early rehab, early get back to work, and sometimes it's a daycare procedure we can do in few of our cases. So with this, I'm ending the instability part, which is on the younger side. When the patient comes to us after trauma with dislocations, inability to throw, they would say, I'm not able to throw a ball, weakness of the shoulder joint. So a lot of young patient, when they come with this kind of post-epileptic patient to us, we can make a good diagnosis with the help of MRI, and we can do arthroscopic procedures if required in their cases. I'm going very briefly for the replacement part as well. So one is a trauma part of the shoulder, which we all manage with, plates and screws, wires. And another thing is your preservation part regarding soft tissue was arthroscopic management. And now we are going to the shoulder replacement part. So likewise, what we see in the knee joint, we heard a lot of different techniques, technologies getting into the knee replacement. The same thing is in the shoulder replacement as well. So here there are 2 different ways. One is a hemi or total replacement, and one is a reverse shoulder replacement. So when I called as a hemi replacement is when you replace the ball on. Total, when you do replace ball and the glenoid as well. So this is a total shoulder replacement. And when I say the reverse shoulder replacement is when you put your ball on the glenoid and cup on the humeral side. So it gets reverse. So that is what is known as a reverse shoulder replacement. So it's a very well established procedure now, and we do it now since more than 10 years now in Baroda itself. So arthritic shoulder we find very regularly, and majority of the cases we get away with the hemi replacement only. So again, in arthritic shoulder, this patient will having bad night pain. They won't be able to sleep. Their range of motions are going to be gradually restricted, particularly the rotation part. These patients are lacking in rotations, and they are not able to sleep on the same side. This patient will typically tell us that he has got a restricted range of motion, and at the same time, I'm not able to sleep on the same side. So these are the candidates. We go with the hemi replacement, and it has evolved in the first, second, and now what we do is a third generation. Many of the fracture cases we do it. This is a first generation X-rays. This is almost more than 15 years of X-ray. What we used to do when I was in SSG, and now we are having modular implants where you can have different size of the humeral head. Right, it's like what we wear, the medium, mid-large, XL size. And for that, you need a modular implants for your replacement as well. So this is how we manage with the hemiarthroplasty. Here is important is you putting your shoulder tuberosities in its place for better function. And this is a reverse shoulder replacement. So when patient comes very late to us, when you see here, there is already fatty degeneration. Your tendon is retracted up to the glenoid. And even if I bring this back here, because of it is a fatty degeneration and arthritis is already settled in, this patient is not going to get result with arthroscopic repair. And that's where we choose reverse shoulder in this kind of cases. Right. This is a very young lady, again, 57 years. She was having pain and difficulty and elevation of shoulder. She is relatively young and need good function, but she came very late to us. It's a pre-operative. If you can see the right shoulder, she is moving from the elbow and not from the shoulder joint. So this is the case when we went for the reverse shoulder. You see the right shoulder. So the reverse shoulder works with the help of deltoid muscle. So when you have got good power in your deltoid muscle. So there are few cases post-traumatic. Here you see again 80 years female patient. Now severe osteoporosis. You need to do straight for reverse shoulder here. And these patients over a period of time will do well. So that's how it looks in the X-rays. This is our new setup. So I shifted during COVID times to my new premises. So formally I cannot invite in Baroda any of the doctors for inauguration or anything. So we have shifted to the new center with all modular operation theaters and tertiary infrastructure, and a very good sports rehab center, one of the first in this kind in the Gujarat, first time, with all facility under one roof. So I thank you for your patient listening, and thank you Satish Bhai for long coordination and dividing into 2 halves. And thank you all of you. We can invite few questions.
Yeah, thank you, Dr. Jaimin. So now the house is open for any questions
Satish
or
Bhai, we
comments.
are not audible to you.
You can't hear me? Hello? Hello?
Yes.
So thank you, Dr. Jaimin. Now the house is open for discussion and comments. Meanwhile, you may stop the screen sharing.
Yes, sir. Sure.
Yeah.
Perfect.
Any questions, comments from anybody?
Only comment is very beautiful setup and extremely good work, doctor. Congratulations on your new hospital.
Thank you, sir.
Yeah, there is a question in the chat box. I'll read it out.
Yeah.
He's Dr. Ganesh Kumar. It is understood that adhesive capsulitis of shoulder is a self-limiting condition in which pain lasts for 12 to 18 months, no matter whatever is done to relieve the pain. Can one shorten this period of natural history of the disease?
Yeah, Dr. Ganesh Kumar. Yes, we all learned that there are 3 phases of frozen shoulder, and usually it gets limited in 9 to 12 months on its own. But to be very frank with you, is clinically when the patient suffers from it, it's a very painful condition. So usually we ask them to go with the good rehab, that is a physiotherapy, right? So physiotherapy is that goes with a passive capsular stretching. So once patient underwent the physiotherapy with passive capsular stretching with good NSAIDs, they do get well soon. Very few patients, non-diabetic, as I told you, we can use oral steroids. I don't use much steroids, but it is there in the our books, it in a lot of literature, so we should be knowing. We can use oral steroids as well. We can use intra-articular single shot of steroid as well to get them relief of pain. And when, particularly I would say the diabetic frozen shoulder, these are one of the worst patients who are suffering because there is a lot of capsular thickening and it doesn't give away with the physiotherapy, doesn't go away with the physiotherapy. So these are the patients where we go in and do arthroscopic release in few of that cases. I hope I have justified your question, Dr. Ganesh.
Ganesh, you want to speak something? Dr. Ganesh was a very regular attendee during our physical meetings, and for last couple of meetings, he has been able to join these online meetings also. Very inquisitive, knows a lot of things about many aspects of general medicine.
Yes. Yes.
Are there any preventive measures to be taken after some age? Like say, is there any cutoff when you would be more concerned about your shoulders? Like say above 50 or 40, you start doing some regular shoulder exercises, something like that.
Yes, definitely, sir. As a surgeon as well, when we do a lot of arthroscopy work, we are in fixed positions. A lot of doctors, means gynecologists, laparoscopic surgeons, you need a good shoulder health. So you need to do very good scapular stabilizer exercises. You need to have we all are gradually getting stooping because we are doing orthopedic work, right? So you need your scapula to be back and down. And you need your scapula to be very strong, like our core muscles. So we say beyond, I would say 45, 50, at least with the help of TheraBands. It's a color-coded bands, elastic bands are available. We need to learn few exercises to keep our shoulder and rotator cuff muscle healthy. So when you get that stretch with the help of TheraBands, your shoulder remains balanced. And once it is balanced, your humeral head will be in the center of the glenoid and your rotator cuff muscles are healthy. So this will avoid any kind of impingement, proximal migration, or even frozen shoulder.
Right. So this applies to everybody, right? It's not about only certain occupations. It's general for all.
Oh yes, definitely, Satish bhai. Because we all do a lot of walk, cycling, we do all those things. But yes, swimming is going to be more helpful, particularly for the shoulders.
Right. Now there is further question like passive capsular stretching. What do you do specifically for passive capsular stretching? He has requested, if possible, please do a demo now.
So usually what happens, initially passive capsular stretching has to be done by a physiotherapist. The reason many of the patient tells us that અમે ઘણી exercise ઘરે કરીએ છીએ અથવા તો we do all yoga and everything. But when the patient is in pain, he cannot do it wholeheartedly on its own.
Right.
So we always tell them, you get the few sessions with the rehab consultant first.
Okay.
Come back to us. Then you can do the same thing once you are relatively pain-free on your own. Yes, passive stretching, let me show you a few of them. So it's this is an adduction. This is how you hold your elbow here and you stretch. So here you are stretching the posterior capsule, right? Posterior capsule. Once you go above your head and pull it back, you can go behind and push it, right? So you can do this inferior capsule. This is your posterior capsular stretch and this is your anterior capsular stretch. So there are different stretches which are available online also. You can do few of the stretches in your lying down position as well, which are known as a sleeper stretches. So there are good figures, videos are available online on Google, YouTube as well. Yeah.
This use of these bands also should be under somebody's supervision initially, right?
Oh yes, we have to learn it very properly because directly using those therabands, because you need to conceptually you need to activate your core, stabilize your scapula, and then you can work on your rotator cuff muscle. So if you do it on your own and directly starting working on your rotator cuff muscle, it's not going to be helpful. Rather, it will be generate more pain later on. So we need to learn it how to do it properly.
Similarly, with weights also, one should be very careful. I mean, I see some young adolescents who go to gym with a lot of enthusiasm. They end up with some pains. They do a lot of weightlifting.
Yes. So a lot of those kind of cases comes to us, and these are particular teenagers, as you said.
Yes, teenagers.
So they do have a lot of injuries. Unfortunately, one of the case what I show where if you see the glenoid cartilage was worn off.
Oh.
So it was in fact a Ranji player. So he came to us very late. And for cartilage, you don't have still a good replacement.
Right. So I think there are no more questions in the chat box at least. Dr. Sachin, you want to say something? Okay, no. So thank you, Dr. Jamin, once again. Thank you for elaborating more on the shoulder issues in part 2. In future, we will have some more talks on day-to-day, what kind of precautions one should take in prevention of all these conditions. So sometime later, we'll have a talk on prevention rather than treatment of the shoulder problems. Along with a physiotherapist, maybe we can have a panel discussion on this.
Perfect.
Okay, thank you all. So we end the session here. We meet next Saturday again. Thank you all.
Thank you, Suresh bhai. Thank you all.